I'm Dr. Scott from Select Pain Care, and I'm going to tell you what we do in our consultations. My job at a consultation is to get the most out of our patients, and here's an example of one of our recent patients. She's a 35-year-old female, a mother of young children. She's been suffering from frontal headaches, so headaches in here, and a pain that goes from her right occiput down to the medial part of her inferior scapula. So like just inside the shoulder blade at the very bottom of it, kind of shoots down there. It's anywhere from a 0 to an 8 out of 10, which is pretty intense. And it feels like it's an ache, stiff, or a tightness, right? So as she looks down at her computer while working, it gets tight. Down in her phone gets tight, her children down tight. But after she does overhead lifting, the things that make it angry, overhead lifting, things are achy or stiff the next day. So her big things that really bother her problem are looking down, sitting for more than 60 minutes at a computer, and overhead lifting. What she has done to make it better so far, that has gotten her limited results, which is why she's at her office, is gone to get regular massages. She uses heat, and she's gotten adjusted. Now, let's go through the process that we use at our office to determine what's going on and how we should examine the patient. All right, now that we know what's going on with the patient, we need to figure out a list of things that could explain the symptoms. So we have a list here of local structures that are right there where the symptoms are, and a list of referred structures are things that could create a pattern that looks like that. So to start off with, we'll start with the local. Semispinalis capitis, it's a muscle that goes from the occiput down that between your spine and your shoulder blade. It's in the neighborhood, it's on the list. Spinal accessory nerve, it has several nerve roots coming out here. It runs down your spine right to the area of complaint. It's a little more lateral than where the symptoms are, but it's in the neighborhood, it's on the list. Lesser occipital nerve, it doesn't do all of it, but it goes from here on up. It's on the list because it has some of the properties, and the dorsoscapular nerve is pretty much the opposite. It goes from the shoulder on down, and it can cause some of the symptoms. So we need to suss out which of those could be going on. Maybe they're all, maybe none of them. We got to look. Then we look at referred things that could create symptoms in those areas but aren't in those areas. So one would be the SCM. It's this muscle right here. There's several nerves that wrap around it that can cause symptoms that go up over here, that go down into there. They could create some headaches, right? And when you have forward head posture, you're looking at a computer all day, definitely on the list. You have the suboccipitals. Those are muscles right here at the back of your skull. You're sitting at a computer a lot, you're doing a lot of this. That would create a band of headache all around that would definitely contribute to some of these headache symptoms, but maybe not the other down the shoulder blade symptoms. Then we have the sclerotome. A sclerotome is as part of a fetal development thing, you just have this pattern. These tissues can refer in these areas. And basically C7 goes from all the way up here, all the way down there, and it covers that area. So those are the things that could be symptom generators. Now we need to figure out, okay, how do we figure out which of these are the problems, which are problems, which aren't problems? On to that one next. Okie dokie, now that we have a list of things that can cause symptoms, we need to develop an exam that's going to rule them in or out, right? All of those things could create symptoms that are causing the problem, but in all likelihood, there's a handful that are really the problem that are creating all the symptoms. So how do we rule things in or out? Well, semispinalis capitis, it's going to extend the head. So we need to check flexion, because if it's limited, we'll know that something back there is also limited, maybe unhealthy. Cervical rotation, that's going to assess these nerve roots out here. Those nerve roots go to other nerves that are on our list. And also those nerves here go into the shoulders. So we need to look at shoulder abduction, because that's going to put tension on those nerves. If they're stuck, it's going to piss off the neck, create some problems. Kneeling hip extension, you might not think about this, but your core has to stabilize your neck while you're seated. So since it's an endurance type thing, any more than 60 minutes of sitting, it gets bothersome. And when she pushes overhead, you need that core to stabilize. that psoas and those structures in your abdominal cavity need to be healthy. And if they aren't, you have less stability for what's up top. And on that same note, that thoracic flexion and extension, your rib cage needs to be able to do all these things. And if it's not healthy enough to do so, it will falter, your head will be in poor position, and then it's going to cause problems. So this is what we need to figure out when it comes to just sheer strength. I also want to look at a push-up to assess, can her neck and her thoracic spine move as one, or does her head have a little bobblehead to it? If that's the case, she has cervical instability, and that could be a component of what's going on. And also, psoas strength, I just do a single leg march kind of thing where you stand on one foot and try to get your thigh as high in there as you can with your knee bent. If you can do that and you don't look too wiggly and you get it up nice and high, your psoas is probably pretty strong. So this is how we're going to suss out exactly what's going on and figure out a plan to restore her health. Okay, so we have done the exam and I have the scores from that exam. We looked at a number of other orthopedic tests as well, but when it comes to our unique functional tests, these were the results. These results, these percentages are based on research on what 95% of the human population should have for amounts of range of motion. So if you're greater than 100%, that just means you have more than that expected range of motion. But generally that means the more bendy you are. When your score is bad, that means it's really bad. So let's look at your scores. 76% overall for cervical flexion. Not great, clearly a problem in the neck, which is why she's getting some of these symptoms. But what's the pain generator? You know, that's a good starting point. Her rotation is better than that. It's 93% to the left, 82% to the right. She has full rotation and flexion in her thoracic spine. So I'm not so concerned with thoracic spine being an instability thing causing pain or symptoms in the neck. Her kneeling hip extension, which is looking at her abdominal cavity where her psoas is, it was fine because it had great range of motion and it passed my strength test. Her neck itself, while limited functionally, had good strength, so I'm not concerned with needing to do some strengthening there. But the big red flag here is her shoulder abduction. And that's a big red flag because one, it's the worst score. And two, if the nerves that leave your neck, right, because she has a lot of tension in here in other parts of the exam, those nerves leave here and they control your pec and your whole arm. Well, if this is also stuck in here, anytime she goes overhead, which is one of her provocatives, it's going to piss off the disc. So those nerve roots pull at the pull and they irritate the disc creates the symptoms, and that is what we are going to say her diagnosis is. She has a C7 disc that's being irritated by peripheral nerve entrapment and likely some nerve entrapment down here, which is where some of her flexion is limited. So we don't need to work on strength, we need to clean these things up, and then I will keep you posted on her progress. So thanks for watching. So here we are. We have a 5-appointment update on our 35-year-old mom who works, and she also has headaches and neck pain. So after 5 treatments, what we have here are, she has no more frontal headaches. No more of those, hasn't had them in several visits. She doesn't have anything at the right occiput anymore. It doesn't go as far as the medial scapula, but it's more of that CT junction, just this tension right around here and just below. So it's smaller in scale. It is condensed down to a smaller area, basically around C7, which makes sense because as you take load off of what the pain generator is, the symptoms will get less intense. They'll have a smaller surface area and then eventually poof, gone. So this is smaller, so that's less. 8 out of 10, no longer. We're at 1 or 2 out of 10 at most. Sitting is when it still bothers her, so we have some work to do. Looking down, same thing. Overhead lifting, she's super surprised. She's got great range of motion here, no longer has that 66% function. She's got full range of motion, none of this bothers her. And we don't have to worry about any more of this stuff. Why? Because we're taking care of what that actual problem is, and then it will come down to her making smart decisions, sitting with better posture, having that awareness, to keep adhesion from building up, keep it at bay, and stay an active, healthy mom.